We know that the data backs the use of PrEP, right? It's FDA approved since 2012, but still there's a lot of underuse of this important preventive method. So I'm here to talk about how do we implement that scientific data with real patients in Puerto Rico, okay? This is real-world data with all the advantages and disadvantages that this poses, okay? Our objectives will be to discuss the current landscape in the field of HIV prevention, including MPEP and PrEP. Why? Because for something like PrEP, we have to consider the healthcare system, the healthcare infrastructure. We cannot talk about PrEP in the absence of knowing that context, okay? Describe potential PrEP consumers' perspective and profile. We're gonna discuss a project we did in collaboration with the SEX team, with Dr. Carlos Rodriguez, in which we gather data regarding PrEP knowledge and acceptability. We're gonna present the demographic and clinical data for our local PrEP clinic and share lessons learned throughout the presentation for achieving sustainability for an HIV prevention clinic, which is obviously an important aspect. We have to recognize that we have to have the funds available to provide these services. So a little bit of background for those of you who don't know our agency. The medical director of PRCoNCRA is been established since 1990. It's a multi-funded clinic, and that is very important to have in mind. I was just recently talking with Dr. Mayer about the HIV care system in Puerto Rico. It's usually mostly based on Ryan White clinics, so that poses a big barrier, an administrative barrier in terms of being able to provide services for HIV-negative patients. We're a nonprofit, community-based organization located in San Juan. San Juan is actually one of the cities including in the HIV epidemic plan for America. We provide comprehensive services for people living with HIV and also for people at risk of HIV infection. It's emphasized on youth and the LGBT population, so we're gonna see that in our data. There's very few women. We want to improve that in the future. We serve approximately 900 HIV-positive patients per year, and in 2016, we established a prevention clinic. It was actually the second PrEP clinic in the island. The first was in Hope Ararat clinic from Dr. Melendez, and it's important to recognize that. Up to this day, in the prevention clinic, it started out as a PrEP. The name was initially a PrEP clinic, but then we changed it to prevention clinic because obviously, as you all know, this is part of a package that includes a lot of other interventions. More than 450 patients have received HIV and STI preventive services, including PrEP for up to this day. So in terms of understanding the scenario on the island, as you all know, Puerto Rico stands ninth among the jurisdictions in the United States with higher HIV prevalence. And in 2015, the Department of Health issued an order, 343, that adopted the 2020 National Strategy Objectives, okay? It said that it adopted it, it didn't say how, okay? In August 2018, they also published PrEP implementation guidelines, also a very, very thorough document. Unfortunately, it doesn't say how to implement it in the clinics, okay? They also have a prevention hotline, which serves as one of the main ways of them referring patients for prevention services, and it manages approximately 200 calls per month, and those patients are then referred for PrEP services. Yet, as we started the beginning, in 2019, PrEP is still not available for people who are at risk for HIV. We have structural barriers. PrEP is not available through one of the most important settings in which it should be available, which is the HIV STI Department of Health clinic. It's not available through them, okay? Possible causes, lack of trained resources to implement PrEP services. There could be some issues with acceptance between the staff. Vast majority of care in Puerto Rico, as I mentioned earlier, occurs within a Ryan White context, so it means that our funds are restricted. In our case, we started off with a 25,000 grant from Elton John Foundation. That was our startup for starting our PrEP clinic, and then we also got an ISR from Gilead, and that pushed our funds, and we were able to start our clinic. Also, there's access barriers, although it shouldn't really be a barrier because of limited insurance coverage, and some private insurances cover it, some Medicaid insurances cover it too, but it's kind of a mess. And PEP, also an enormous gap in access. It's only reserved for people who are victims of sexual assault, and they are to emergency departments. So there's an enormous gap there. So that means that only a handful of clinics like us are the ones who are offering PrEP in the island. And this is, I'm sorry. How do I go back? Where? Oh. Okay. So I'm going to make reference to this data here that says it's a study that showed the prevalence of pre-appropriate prophylaxis use and PrEP to need ratio in the United States in 2017. And this is a longer list. I just took a fragment of that list. What they did is that they matched the prevalence of HIV with prevalence of PrEP use, and then they identified those areas who are actually meeting their goals and those who are not. We are the ones with the lowest PrEP to need ratio at 0.1. Okay, so we are lagging way behind, okay? This is data from AIDSview that shows that in Puerto Rico in 2017, we had 455 new infections at a rate of 15 per 100,000 populations. And in 2018, we only had, according to this data, which is not necessarily all-inclusive, only 98 patients were on PrEP. This is based on claims from medical insurances. It was also through Gilead, with a PrEP use rate of 3 per 100,000 patients. So that gives us the 0.1 ratio. So we're going to start off with the perspective from the consumers. We did this in collaboration with the SEX team from the University of Puerto Rico. It was a questionnaire that assessed our MSM population knowledge and acceptability regarding PrEP. It was conducted from 2016 to 2018. We interviewed 189 MSMs with a median age of 29 years old. And this is the information regarding their insurance coverage, which is important. Unfortunately, it is important to have that information integrated in this. Almost half of our patients were privately insured, 30% had Medicaid, and 17% were uninsured. As you can see, a vast majority of that cohort of patients was between the ages of 20 and 29 years old, almost 60%. 86% of those patients have heard about PrEP, 84% will probably use PrEP, and 85% will be comfortable using PrEP. And even at that point, 75% were interested in PrEP at that time of the interview. Yet, only 26% of those patients had actually talked to the healthcare provider about PrEP, and probably that number is even lower, okay? 44% were worried about possible side effects. And you're going to see throughout the presentation that we use the promotions that we put through our website and to the Facebook and other similar pages so that you have an idea of the ways we reach out for patients. Remember that this population size was 183. We noticed a high prevalence of HIV risk behaviors in that population, a high use of alcohol and drug abuse. Almost 100% of our patients have ever used alcohol, and a third of them had used poppers in the prior 90 days. Okay? Also, an average events of receptive anal intercourse within 90 days was 8, with an average of 3 partners, and 45% of those patients contacted their latest receptive anal intercourse partner using social media, and we know that that's a really red flag for HIV risk. Also, we assessed use of condom. Only a third of the patients interviewed referred that they always use condoms. Never use condoms. Almost half of our patients never use condoms with a regular partner. Okay. Also, group sex was also very interesting, that almost half of our patients, more than half of our patients, have engaged in group sex. and use of drugs or alcohol during group sex was almost 75%, okay? Use of drugs during receptive anal intercourse in this group was 65%. So those numbers are really impressive, okay? These are patients who come through our prevention center, which is kind of another sector within the clinic, and they just come for HIV screening and counseling, okay? That is not in the actual prevention clinic yet. Those patients are not already in the prevention clinics. So what has been our experience in CONCRA? We recruit our patients basically through our in-house HIV testing, and from there we link them to PrEP services when we identify they are at risk. We get referrals from other institutions, we get referrals from the Department of Health, and we also have a strong presence on the social media. Just to give you an idea of our seropositivity rates, it's been close to 3% for the last 3 years. Obviously in 2017 something happened which affected a little bit our ability to do HIV tests, which was Hurricane Maria, okay? So basically a positivity rate of 3% among our center visitors. This is the cohort of patients who have been in the prevention clinics. It's 474. That includes patients who come for PrEP, but also includes patients who come for HIV and STI screening, okay? So it's not the totality of patients who are on PrEP. The average age for that population is 32 years old. 63% of them are male and 16% are female, just 0.4% are transgender women. Age distribution, 60% of our patients in the prevention clinics are between 25 and 44 years old, and we have patients who are older than 65. Okay. Risk factors. The most prevalent risk factor is being a high-risk MSM, 55%. High-risk heterosexual population, I think, is significantly high, it's 24%. 16% are patients who are in a serodiscordant, a serodifferent relationship. 3% are bisexual, and 1% just didn't report. 25% of these patients have been diagnosed with at least one STI, with the highest prevalence being chlamydia in 43% of those who have been diagnosed with an STI, followed by syphilis, gonorrhea, and Hep C. This may be underrepresented because we're only taking into account the testing that are done in-house. Okay, so the prevalence for these STIs in this 3-year period has been 11% for syphilis, just 1% for Hep C, 13% for chlamydia, and you can note that there's the highest prevalence is chlamydia in the cervix, although the sample was very small, but it's the most significant and the most prevalent. It's important to signal that. Gonorrhea with a 5%, and as you can see, we do urethral, anal, and cervical screening, okay? And as Dr. Mayer mentioned earlier, a high percentage of our PrEP patients are the ones who have the STIs, with 68% of STIs occurring among PrEP users, which is good from in one point of view, because this is the type of patient who has to use PrEP. So it's an objective indicator that that patient really is a candidate for PrEP. So this doesn't necessarily mean that they acquired the STI while they were on PrEP, because we don't have that data right now. The numbers are too small in order to make that analysis, okay? Other clinical indicators, 64% of our patients have seroconversion against hepatitis B, 2 chronic infections with a 0.6 prevalence, and 1 acute infection which was diagnosed during screening at 0.3%, and natural cure or seroconversion at 3%. And also of note, very important, 45% of our patients, our MSM patients, have an abnormal anal cytology, and for most of these patients, we are the only site where they can actually go to have an anal pap smear performed. Going in the line with Dr. Mayer's presentation about PrEP providing a gateway for primary care. Okay, so we're filling a gap in terms of having access to this important screening method for MSM. We have had no discontinuations due to adverse events. We have had discontinuations for other reasons. For example, maybe the patient's thinking that he has an adverse event. We have had one pregnancy within the prevention clinic. She's currently, I think, in her latest trimester. It was a serodifferent couple, and they were using time unprotected intercourse. So far, she has retained negative. HIV incidence within the prevention clinic, we have had 3 newly diagnosed cases which were identified upon initial screening in the last year, and 1 seroconversion on a patient who was previously on PrEP and had discontinued PrEP for a year. We did a genotype on this patient and nothing. There's no associated mutations. There's no resistance associated with any of the components of PrEP. So up to now, we have no seroconversions of our PrEP patients who are under follow-up. Also, even though we don't promote the service of NPEP, we do provide it, because when we are doing sexual interview for our patients, this is the single most important sexual history question you have to make to someone you're offering PrEP. When was your last unprotected sexual encounter? Because it will trigger whether you're gonna move that NPEP prescription or is it gonna be PrEP, okay? So even though we're not promoting PEP, we have seen 53 patients already in our prevention clinics who have been prescribed PrEP, 5 of whom have been lost to follow-up, and we just didn't see them again. And 35% have transitioned to PrEP. We would like to improve that number, and the vast majority of them have them transition to PrEP, because patients who receive NPEP have 4 times a higher lifetime risk of acquiring HIV. So for us, transition to PrEP is a seamless process. We usually just schedule an appointment in 3.5 weeks before they finish their PEP medication, and then we just transition those patients to PrEP. In terms of retention, and really there's no clear definition of retention in the context of PrEP. We try to extrapolate what we know and what we use for HIV, but that's not really accurate, okay? We have, out of 233 patients who have received PrEP, we have provided a total of 1,600 services in September of 2016, with an average amount of visits of 3.5. Only 10% of our patients just come once. The vast majority of them come repetitively. Most of them come from 2 to 5 visits, okay? Our overall retention, including patients who are on PrEP and patients who come for a STI clinic, is 8 months, and our average retention in PrEP is 13 months. We look back at those patients who we enrolled very early on, and 54% of them have had at least 1 visit in 2019, so I think that's significant. Doesn't mean that necessarily they have always been on PrEP, but they are still retaining PrEP services, okay? This is just to give a context. This is a project that was carried out in Rhode Island, Mississippi, and Missouri. I think Dr. Mayer is also one of the investigators involved in this study. It measured retention in PrEP care in 3 U.S. cities in 2000. It was published in 2016. And as you can see, in total, taking into account all 3 scenarios, retaining care at 3 months, overall, it was 33%, and in 6 months, 60%. I think looking back at the demographic of those 3 populations, we are probably more similar to the Mississippi cohort. They had a retention of 70% at 3 months, and then 62% at 6 months. It was basically, the Mississippi cohort was a scenario similar to us. It was an LGBT community. Obviously, in terms of demographics, Rhode Island had a 25% Latino population, so probably we're a hybrid between those 2 populations. And this is our data. We analyzed patients from 2018. 87 patients were prescribed PrEP, out of which 76 actually used it. And we had a 3-month retention of 62% and a 6-month retention of 54%, with an average retention of 6 months, okay? So I think we are between the lines of Mississippi. So what are the issues with retention? What do we have to take into account when we are considering retention in PrEP care? This is not a chronic condition. These are healthy individuals, okay? So there's also limited resources. In our case, we have limited clinic hours. We started out with 4 hours every other Saturday. That's how we started. Right now, we just have 12 to 15 hours a day to provide the service. Not all services are free, unfortunately, and also that risk might be seasonal. So we have to also really rethink about how do we define retention in PrEP. What can we do to increase that retention, increase available clinic hours, and also have flexibility? If you're ever trying to implement the PrEP clinic, consider that if a patient has an urgency or an emergency, you have to be able to figure out how to manage that emergency, even if you have restricted time for providing the service. Offer free HIV testing, access more resources to offer more free wraparound services. We have identified that this population has a big need for mental health services, and once we started providing that service, we also noticed an increase in retention, and also try to incorporate other modalities of healthcare services provision, like, for example, telehealth, as Dr. Mayer mentioned. In terms of access, in spite of uneven and undercoverage by private American insurance, access shouldn't be a barrier. Or of our PrEP patients, 45% are through patient assistance programs, 45% through their insurance. Okay, so really access shouldn't really be a problem for our patients. Through the Gilead's patient assistance program, there's really just a handful of patients who don't qualify for some type of help. So, focus on the outcomes. Focus on the outcomes, okay? We just need one case of a patient being on PrEP to become HIV positive, to just make everyone doubt our ability to provide services, okay? So try to focus on the outcome. We keep close surveillance of our patients, especially new patients, establish procedures that allow you to expeditely review labs and to manage them accordingly and expeditely, and try to adhere to that 1 week period window for your baseline HIV test, okay? Also, be flexible in your services, devote personnel exactly just to manage medication access. You just need someone, a coordinator, a PrEP navigator, who will just manage the access. And with that patient, person, you're going to be able to handle the biggest barrier, which is access. And also, when possible, try to cover other significant wraparound services like labs, mental health, etc. This is our faculty. This is all of us. Some of them are here. I want to thank you. I also want to thank the SEX team and the Department of Health for collaborating with this presentation. And if you want to hear more, because we are out of time, I invite you to LASOS, which is our annual educational activity, which will be right here in this hotel on the 12th of October. So.